Okay, welcome. Today we're going to talk about adjacent level degeneration of the lumbar spine. And sorry about the misspelling of lumbar. I know how to spell it, but
That's good.
you know, it's a Christmas season. It's really busy. Had to
It's
put
in
up
Puerto Rico, isn't it?
that. Okay, do you know who were that? Have you been there, David?
Palmas de Mar.
That's Miracle on 34th Street. You guys been there?
The other side of the street looks the same, right?
A little different. That's in Hamden.
Oh yeah, I've been there one time.
Yeah, it's nice. So what happened? So this is a case presentation where we're going to go over a case, and what happens in the spine is you fix one level, and then the next level goes bad. So it's called adjacent segment deterioration. So I'll tell you exactly what it's about. That's what this conference is about. So we have an illustrative case. This is he's not the patient. This is just a mugshot of somebody the same age, but he kind of looks similar. It's a 51-year-old man, just to get you an idea that this is about a human being. And he presented to my office with low back pain, left greater than right lower extremity pain, and right foot paresthesias. He had terrible low back pain. He had it for years and years and years, and he's been just putting up with it, and he finally couldn't take it anymore, and he came into the office. So his chief complaint was low back pain. His entire left lower extremity was painful and numb in a non-dermatomal distribution, so it was just the whole leg was painful. And his right foot was had pins and needles on the bottom part, plantar aspect. His past medical history was significant for he had a spinal fusion from L3 to S1 11 years ago, 2013, that he says went very well. He didn't remember, but after review of the medical records, he was also taken back to surgery on post-op day 3 to explore his right L5-S1 nerve root. So I just got all the operative notes because I wanted to find out the screws, and I found that out. He didn't tell me that. He's a very nice man. He's married, children. He works as a boilermaker, welder. He has he's kind of a large man, 6'2", 215 pounds. And on exam, the most relevant portions of his examination is he walked with a flexed forward posture or bent forward posture, as if he had lumbar stenosis. So does everyone know what that is?
Leaning on a shopping cart.
Yeah, when you go to ShopRite at Klein's and you look carefully, there are many people that lean forward on their shopping cart just because you probably just notice them, maybe because they're in your way, etc. And the reason why they do that is they have lumbar stenosis usually, and when you flex your lumbar spine forwards, it stretches the ligamentum flavum and it opens up the spinal canal. So when you have lumbar stenosis, that's a compensatory measure that most people do to relieve their low back pain. When it gets real bad, like my dad, they just sit down. They just go for grocery shopping. They say, I'll sit at the front, you get everything, and I'll meet you at the front. So when you sit down, it also opens up your spinal canal too, by the same mechanism. He also had on exam, and I examined him very carefully, and Aaron can attest. Oh, shoot, Aaron can attest to this. Hold on one second. So Aaron can attest to it that he had a 30-degree flexion contracture, and I'll show you what that is in one second. So these are military recruits, and I have a personal theory of why the military, all world militaries, when you stand at attention, they have this posture. Does anybody have any theories? I mean, every single one has the same posture. No military slouches when they're at attention. And I think it's because this position is the most comfortable position to maintain this position for hours. And why is that so? It's because the spine is completely balanced. The head is over the pelvis, is over the feet, is over the hips. And when you can maintain this position for hours on end without flinching whatsoever because you're balanced. And it's the most ergonometry, what's the word I'm trying to say? Ergonometrically most balanced position. So exactly the plumb. There's a plumb line, which is a gravity line, which is normal. That starts in the head and it goes through C1 and then T1 and then it goes anterior to the thoracic spine. It goes through the L1 vertebral body and then the anterior third of the sacrum, and that's the most balanced position of the spine. So you can imagine if you flex your lumbar spine, you're bent forwards, and it's not a balanced position, and it's exhausting to walk like that. The other issues that are important is the sacrum and the pelvis. So the sacral slope should be 40 degrees roundabouts, and then also the pelvis and the hips are related in these two measurements, pelvic tilt and pelvic incidence. So you can change the position of your pelvis, but also your pelvis is made in a certain way, like it develops when you're in childhood in a certain way, which may affect the balance of the whole spine, because you can imagine looking at this, the pelvis is connected to the sacrum through the sacroiliac joint, so the shape of the pelvis also affects basically the takeoff point of the spine at the sacral slope. So if you have a deformed sacral slope, everything's resting on that, so that the alignment of the pelvis is basically the base of the spine. So what problems could happen? I mean, typically, normally, the sacral slope is 45 degrees. You have lumbar lordosis, thoracic kyphosis, cervical lordosis, and your head should be over your pelvis, which is just slightly anterior to your hip joint, and then goes to your knees and your ankle. What happens in people, the next one over, you can see at A, and then it says L. If you remove your lumbar lordosis, you're pitched forward. Now you can cheat by flexing your hips and knees and rocking your pelvis to stand upright. Does everyone understand that? So that's what a lot of people do, and that's what this guy does. And then when you do that, you develop flexion contractures if you've been doing it for a real long time. So again, this is another example of a normal military posture on the left, where the head is over the pelvis, is over the feet. And you can also see if you have a good posture by putting your the heels, your buttocks, and the back of your head up against a door. And if you can do that, that's the correct military posture. That's very comfortable. You can stand like that for hours. Now, I would say 99 out of 100 people do not walk like that. Would you say that's correct? And why that's so, I don't know. I think as we get older, like there's another thing in spine that everybody says is that age is a kyphotic. Age causes kyphosis. So as we get older, everyone becomes kyphotic. Like gravities just bring us down towards the ground. Not everybody, but most. So this is just an example of the spine. It should be balanced, but as you lose your lumbar lordosis, you're pitched forward, and it's a very exhausting alignment. So normal lumbar lordosis, I mean, what's normal is it's a very wide range. It's anywhere between 35 and 55. Most of the lordosis is in the lower lumbar segments from L4 to S1, as you can see on this table. This is the lordosis you get at each level. So most of it's at L5, S1, and then L4, L5. At T12, L1, L1, L2, the spine is mostly straight. So flexion, what are hip flexion contractures? The bottom one shows a man with bilateral hip flexion contractures, where you lay him flat on the table and he cannot maintain a straight position. So this is what he did in the office while he was awake. Interestingly, when we put him to sleep, he was flat as a board. So he didn't have a hip flexion contraction. All that was just, it was basically spasms and protection of his neurological elements because of the severity of his stenosis, which was very interesting. So he was spastic in the office. He would not let us do that because his nerves were so compressed. And people have guarding of their bodies while they're awake. When they're put asleep with general anesthesia, you don't guard yourself and you can remain flat. And that is why some people, when they're put to sleep, become paralyzed, because they have severe stenosis, usually of the neck, and they constantly guard themselves. So did I ever tell you the story of the Iraqi girl that wouldn't let me touch her chin when I was a fellow? There was a 10-year-old, maybe 9-year-old Iraqi girl that had a severely deformed cervical spine that she got from some kind of toxic exposure when she was a baby, and in the night this was when I was a fellow in 1996. So it was she was exposed like around 1990 to some nerve agent, and she had a severely deformed cervical spine. Where she wouldn't let anybody touch her. She kept her hand on her chin. She had been doing that for like a year, and she would never let anybody touch her chin. Everyone thought she was crazy, but in fact she had an extremely unstable cervical spine, and she knew that if anybody touched her chin, something was extremely wrong. Basically, she would go paralyzed. So she was guarding herself by holding her chin. She never let go of her chin. And then we got all the imaging and realized she had this severely deformed cervical spine from this anomaly of her cervical spine that we fixed. But I'll never forget that for the rest of my life, that you do have the capacity to guard yourself. You don't know why you're doing it, but you do it. And when you're put to sleep in a bad position, you can become paralyzed because you stop that guarding and the spinal cord becomes compressed. That's why in severe cervical stenosis, the anesthesia people know to keep the neck flexed when they're put to sleep, and then they let the surgeon do the final position. That's why when we do cervical stenosis, when I do that, we get a pre-flip baseline or pre-positioning baseline just to see if we did anything to the spinal cord. The Neuro Monitoring should tell us, and then we can change that position. Does that make sense, Aaron? Okay. I like to explain things to you so you know the things I do. So in this guy, when he was put to sleep, his legs went totally flat, which was interesting. And the way you can examine a hip flexion contracture is on the patient's side. You can see how far back you go. So I did this in him, and in both ways he was 30 degrees flexed. And you can cheat with flexion contracture too by arching your back, and usually children do this because adults are too stiff to do things like this. But children can cheat by arching their back, and then you measure the hip flexion contracture, and you're not really measuring it, because what the kids do is they have extremely flexible spines, and they can change their positioning. So here's the x-rays of our patient now. Back down to our patient, 51-year-old man with low back pain, left lower extremity pain. And what do you see on the x-rays, Aaron?
Instrumentation from L3 to S1, and the S1 screws are broken.
Yeah, that's about right. And the alignment?
Not great. 3-4 has spondylolisthesis. 5-1.
Okay, so there's L5-S1 spondylolisthesis, and he's also tilting towards the right. And most of that tilt, where do you think that tilt is coming from? Can you guess?
2-3.
Looks like a lot of it's 2-3, right? And on the side view, you look at this is a standing view. You look at the lumbar lordosis. So just to grade it, the sacral slope is about 45 degrees, which is good. It's about normal. The L3 vertebral body should be horizontal to the floor. Good morning, Doug. Should be horizontal to the floor, and it's slightly bending down. The lumbar lordosis looks pretty good. It's about 35 degrees. So here are the broken S1 screws. Why are the S1 screws broken? Because they're a bad manufacturer? Anybody know?
There's movement.
There's motion, yeah. So there's motion across the L5-S1 interspace such that eventually the screws break. So, Doug, can you tell everybody the association of fusion or fracture healing versus implant versus failure? What do we always say as orthopedic surgeons?
It's a race to fracture or fusion versus implant failure.
Fracture. Well,
Fracture healing.
fuse the fusion or the fracture. That's what you meant to say, right? So it's a race between fusion of the fracture, fusion of the spine versus the implant failure, and who wins? And there's the question: who's going to win? Who's faster? Is it the implant going to break first, or is the fusion going to take? So which one won in this one?
The implant broke first.
The implant broke first. Yeah. Now, if an implant breaks, does that mean the spine will never go on to fusion or the fracture will never heal? Who can guess?
Not necessarily.
Not necessarily. It may still go on to heal. It's obviously suboptimal, but it still may go on to heal. So let's see if this guy went on to heal. But when you see that, you're very suspicious. So on flexion extension views, he didn't have much motion at all. So here's his MRI scan. Aaron, what do you find on the MRI?
Same thing, L5-S1 spondylolisthesis.
L5, oh, you're really fixated on that. L5 is spinal stenosis. What else?
We were just talking about
Spinal canal and the sagittal cuts?
let's see, 2-3 stenosis.
So 2, 3, and 1, 2 are very stenotic. You can see that on the sagittal cuts. And T12L1 has a slight disc bulge, but the spinal canal does not look very stenotic. So the spine is made up of a large vertebral foramen, or the spinal canal, a pedicle that connects the backside posterior to the anterior side, a lamina transverse process, and a posterior spinous process. So here is at T12. Does this look normal, abnormal to you, Aaron? What do you think?
Normal.
Pretty normal. Large pedicles, large spinal canal. You can see the very remnants of the spinal cord. So at level L1, what am I measuring here?
Size of the pedicle.
Size of the pedicles. So Brian, what's the smallest pedicle screw that you have for the lumbar spine?
4.35 millimeter diameter.
4.35? Okay. So he's really close at L1, whether we can use it or not. Spinal canal is big. How about L1, L2, Aaron?
That's a terrible picture.
Yeah, but how about the spinal canal? Spinal canal here versus spinal canal here?
Oh, stenotic.
Severely stenotic, right? How about L2, L3?
Stenotic.
Severely stenotic, right? So the spinal canal should be a big circle like that, and it's a really small area at L2, L3. How about L3 spinal canal, the level of the pedicle screws?
Not bad.
Spinal canal looks good.
Huh, I'm
L-
not seeing these. I'm not seeing these.
The spinal canal is the tube where the nerves run in the spine. So
Right.
here's the spinal canal.
They look pretty much the same to me.
Okay, just keep a close eye. Compare this circle, okay, with this circle. And that can't look the same to you because this is not even a circle. Look, this is like, looks a little bit like a flat as a pancake. See that? So it should be a big circle.
Okay, that's
So the spinal canal is severely compressed from a disc bulge, but also from hypertrophy on the backside of the facets and ligamentum flavum. So 3-4 is wide open, right? The spinal canal. 4-5 is wide open. I just wanted to show this, that on the left, the posterior iliac crest was harvested, and you can see that right here. Compare this crest to that crest. You see how this one's kind of destroyed? So the way that the previous surgeon did this is that he did the standard approach where you just shave down like that and just take everything off. You shave down like, to take away the lateral cortex and then take all the ilium and then just let it heal like that. And it kind of grew in a little bit, or he didn't take that much. It should look like this. You see that? So basically the previous surgeon made a cut from here to here and took all that off and used that for bone graft. Now I do it a different way. I used to do it like that for years. So again, this is it. So I did also got a CAT scan to see if he is fused and looked at the screw position. And look at L5S1. He's solidly fused there. See that? You see the bones connecting from here to here? So he solidly fused the L5S1 segment. So even though the screw won in the race for failure versus fusion, the fusion and the implant broke, it still went on to fusion somehow, which is good for him. And you can see the rest of the spine is solidly fused. You can see the posterior elements of the spine here are solidly fused. See that? So from L3 to S1, he's solidly fused. And that, is good for operative planning. So again, T12, you can measure the pedicle better with the CAT scan because the resolution is higher in a CAT scan for this sort of thing, looking at bones. So T12 measures 8 millimeters, but L1 only measures 5 millimeters and 6 millimeters. So it's very difficult. It's going to be very difficult to put a screw in there. And the other thing on the CAT scan shows the hypertrophic facets, and you can even see the facet capsule is somewhat calcified here too. See that? It's kind of interesting, right? So when we remove that capsule, it can be weird. Sometimes it can even be totally calcified sometimes, but that's rare. But that can happen too, and that's why when I'm doing this case and I'm drilling down ligament flavum, I'm like, man, this is weird. This whole thing is calcified. It's not supposed to be calcified. That's why I say that sometimes. So at L2, L3, the same thing. The facets are very hypertrophic. So here's the L3 screws. Do you think these screws are good? Are they all right?
Looks medial.
Medial,
Right.
but
Whole width of the pedicle.
Yeah, but this one's pretty. At L3, it looks like it's inside. It's medial to the pedicle. Is that a problem?
Yeah.
These screws have been in there for 11 years. Here's another view. Does it look okay there? Okay, now why does it look okay in one view and not in the other?
Is it rotated?
Anybody guess? How can that be? Does anybody know?
Different angle.
the pedicle narrows proximally.
Okay, it's kind of both. So it is a different angle in the pedicle. So here's a view of the L3 pedicle. It's not a circle, and you can see this is a coronal section through the spine, and you can see where the medial nerve root runs. It really hugs the pedicle, doesn't it? So if you have a piece of metal right here sticking out, is that good or that's bad? It's bad. It really causes pain. And you can see the pedicle has got an unusual shape. It's not this oval. It's like it goes down a lot. It's not a perfect circle. So when we put pedicle screws, we're trying to put a perfect circle into something that's not a perfect circle. So basically what we're probably looking at in the CAT scan is the one view, we're looking at a cut through here where the screw is, fine. And the other view, we're looking at a cut here where the screw is medial. You see that? So that's why the CAT scan looks like that sometimes. And here is the pre-op CAT scan of L3. It looks okay, but it's very close. Again, this person did fine for years and years, so I don't think it's a problem. Otherwise, he would have had pain immediately. And here's 4, which looks a coronal section through the pedicle, which looks totally normal. L3, L4, I just showed this, and you can see that the facets are fused here. You see how the facets from here to here are fused. If it wasn't fused, there would be a black line. And he's got a lot of bone graft posteriorly. Here's the placement of the L4 pedicle. L5 pedicles are good. The left S1 screw is a little bit suspect, isn't it? But he didn't have. You can see the ilium on the right there where he took the previous bone graft, what it looks like on the CAT scan. So here's the problem list. First is he needs to. What's problem number 1? What's his main problem? What do you think, Doug? What do you think his main problem is? Like he's coming to the office with low back pain.
Probably L1, L2.
Yeah, stenosis at L1, L2, L2, L3. So that's number 1. So we have to take all that out. Now we're going to decompress above a previous fusion. That's going to weaken the spine. So I think it needs to be fused. I mean, you can argue that, but I mean, to do a full wide decompression and not worry about instability, it's a lot easier to fuse it. I think most people would agree with that. So first thing, you got to remove the implants. We got to find out what the implants are, which are very hard. Most surgeons don't dictate what the implants are in the operative note because they're lazy. So it took a long time to figure out what they were, and then once you do find out, it's not guaranteed you're going to get the screwdriver, or the screwdriver exists. And every company has their own proprietary screwdriver, so that it's not standardized, so that you have to buy everybody's instrumentation. So it's very difficult sometimes to take these implants out. You also have to avoid the dura at L4, L5 because there's a defect there because he was decompressed. You want to make sure he's fused from L3 to S1. We think he's fused because it looks like that on the CAT scan, but we should make sure of it during the surgery. If he's not fused, you have to put bone there. The question is, do we put iliac screws or just put the old S1 screws? Do we look at the left L3 screw? So we do have decompressed L1, L2, L2, L3. Do we put a pedicle screw at T12? Do we do a pedicle screw at L1? Do we try just do pedicle screw at L1? If we take iliac crest, it should be on the left side. The right has been harvested, but you can still harvest it, but it's a lot harder. Do you use bone morphogenic protein, vancomycin powder? I think the answer is yes in the spine. So any questions or comments about what to do with this man with adjacent segment deterioration?
And what comprises a decompression?
So decompression is just take the pressure off the nerves.
How do you
you take a drill and a microscope, and you drill down all the way down to here. Take all this off. Basically, you take little picks and you pick it off. So to remove the posterior elements there at the spine. Okay, so adjacent segment generation. This is the latest article that I read 30 minutes ago in 2014. It was an online article. The senior author was Ed Benzo, who's the neurosurgical chairman at Cleveland Clinic, and it goes over adjacent segment disease. So there's a big push now in orthopedics to do artificial disc replacements. Why? Because if you fuse something, you get adjacent segment deterioration, just like this guy did. And this article basically reviewed a PubMed review of 850 articles. Out of those 850, they went down to 41 articles that they felt was worthy to review for their criteria. And they're the people that get. So there's a couple issues at hand. First is adjacent segment disease versus adjacent segment degeneration. So if it's symptomatic, it's a disease. If it's just on an MRI or CAT scan, it's just degeneration. And the incidence of adjacent segment disease is about 3% a year. So if you do a fusion and you follow these people, 3% a year get disease where the next level goes bad. And they found no difference between total disc arthroplasty versus fusion. So everybody deteriorated about the same rate when they reviewed all these articles. So who gets deterioration? Who's at risk? It's people who are fused in a kyphotic segment. So you see the leaning tower of Pisa here. There's a lot of stress on the base there, and it's a very high chance that building will fall because it's not aligned perfectly. So it's the same thing in the spine. If the spine is not aligned perfectly, there's a very high chance to get a problem. So the risk factors of adjacent segment deterioration in this review article, they felt from reviewing all the literature, was first it's just normal natural history. You're at risk if you have biomechanical stress. So in other words, your fuse or your alignment's off, and it's usually kyphosis. It's like you have excessive kyphosis. And the other risk factor is anatomical disruption. So if you do an operation and you disturb the annulus of the cervical spine, you disturb the disc, you disturb the posterior elements from your previous operation, those people deteriorate too. So any questions about? So it's a little bit of a monkey wrench into the arthroplasty. So this is our case from last night. So he basically has an L1 to S1 fusion now. I could not take out the L3 screws or the S1 screws because we didn't have the right screwdriver. So I just left them in place and incorporated them with the new implants. And I was successful in putting in an L1 screw, even though I thought there's a good chance I may not be able to be successful. And I did a revision decompression, L1, L2, L2, L3. So you can see the defect on the AP view right here. See this big defect? So this whole area was opened up. It was very difficult and very stenotic. I mean, Aaron can attest to that. And I took out the old screws. Here's the old screws. And the inside, this was an inner port cross implant, and the inside was a hexagonal shape. And I got some of them out, but I couldn't get all of them out because I didn't have the specific screwdriver. So here's my L1 screws post-op. And I also did neuro monitoring. I checked them with electricity, and everything was normal. You see the right L1 screw is very close to the medial border. But, I mean, I palpated it, but sometimes you can be wrong with palpation too. It feels fine during the surgery. Here are the L2 screws. And when I say check it with neuro monitoring, what we do is we put a probe on the screw, and we put electrical current through it, and then we also have these probes in the muscles. And if the nerve is being hit by the screw, the muscles should fire.
Huh.
So we tested all the screws and they were all okay. So here's a sagittal cut, and on the sagittal cut, you can see our decompression is good. The decompression goes from here to here. See that? So all the posterior elements there have been removed. And on the coronal cut, I just put this in so you can see our bone graft. So you can see our bone graft all here in the posterior lateral gutters. You see all that bone graft? And on the other view here. So all this was fused. because we decompressed it above L3 to S1, and we didn't have to do anything about L3 to S1 because it's already fused. And these are the L1 screws, coronal sections, so you can see they're well within the confines of the pedicle. But there is like one tiny area which looks suspect, right? But I think it's okay. And this just shows the technique that I do for bone grafting is I just cut this, remove that, and then I scoop everything out in the middle, and then I backfill it with allograft. And then when I do CAT scans or MRI scans a year later, it's totally normal. So, have you ever heard of this, Doug? So I got it from the implant companies because they said we have this new filler for your bone graft. I was like, really? So I thought about it. I was like, why don't I just use allograft? It's a natural substance. So I've been doing it like that. I think my results are better. I mean, the anatomy in a year are totally restored. So that's it. So any questions about adjacent segment degeneration? This case?
Just the surgical techniques. As a non-surgeon, I'm not familiar with what you're doing.
You know what? I'm not prepared to show that to you right now, but can you give me your email? And I have another lecture that I did just on that topic. I'll send it to you on how to decompress the spine. And
It's quite interesting. It's very interesting.
yeah, if you give it to me, I'll send it. All the instruments we used, the picks and the drills and the instruments. Any other questions about adjacent segment?
In the articles that you sent, there was a point about violating an adjacent disc during the prior surgery.
Right.
Do you know, is there a study on percentage of adjacent when that disc is violated? Like say a probe or a pedicle screw goes through a superior ankle.
Yeah, so if you put a needle into a cervical disc,
Right.
you know how we always do that?
Right, to mark your levels when you're
It increases the chances of degeneration 3 times.
3 times.
And in fact, there's a rabbit model for degenerative disc disease, and that's their model. They put a needle into the disc of a rabbit, and it deteriorates. So that's why a lot of surgeons don't put the needle in. But the other thing is Dan Rue did a study where he's got this. It's been a pet peeve of his that you don't violate the anterior longitudinal ligament of the next disc up. So you want the shortest possible plate as possible in the neck. So that's why I put a super short plate in the neck, because if you violate the anterior longitudinal ligament of the disc above in a cervical spine, there's a very high chance of it increases the deterioration rate significantly.
That paper, if you're within 5 millimeters of the neck, right? I think there was.
Yeah, if within 5 millimeters with your plate, there's a high chance the next one will deteriorate. So you want to, and it makes sense. You don't want to destroy the architecture. Same thing in the lumbar spine. If you decompress the level above a fusion, there's a higher risk of deterioration. Or if you remove the facet. So any other questions about anything?
It's all very interesting. Thank you.
Oh, you're welcome. Any other questions about lumbar disc disease or adjacent segment deterioration in this case?
I know not to try to sell you on Pro Disc now.
Who, me?
Yeah.
What is your, Doug, what is your take on artificial discs as orthopedic surgeon? It's a very controversial subject in society. We all talk about it. Do you have any thoughts or opinions? No?
No.
So my thought...
Not ready for prime time yet.
Artificial discs?
Yeah.
Yeah, that's probably true. I mean, not clear when you should do it and when you shouldn't do it. I don't see why you would do it. I mean, to retain motion, yeah.
And what about
Implants are 3 times. It's like $10,000 versus $2,500 for plate and screws.
I didn't read the article, but not too long ago, there was a study of kyphoplasty, right?
Yeah.
And it showed there was no difference between what? Not sure.
Well,
But
the
was-
government had 2 studies that they did, and they were great studies. They were sham surgery studies, which only the government can do. And they said they did kyphoplasty and they didn't in some people, and those people got better. So the question is, like, do kyphoplasties do anything? But there are some problems with the study because the kyphoplasties were done 2 weeks out. So basically, people broke their spines and they let them suffer for 2 weeks, and then they did the kyphoplasty, and they found that it didn't make a difference if you did kyphoplasty or not. But it was a really weird study because, first of all, that's not what happens in the real world. In the real world, the people who are fine, you don't do surgery in those anyway. They just walk around. They're like, I'm good. I don't need anything. All right, fine. See you later. But the people who can't move, those people do very well with kyphoplasty. So, and they usually get the kyphoplasty in a day or two. Nobody lets them sit in the hospital for 2 weeks. So it was a weird study. I mean, the government did it on purpose so they don't have to pay for kyphoplasties.
Huh. But that technique is still with a balloon or whatever blowing up the.
It's a good technique, but it should be. I mean, this is my opinion for what it's worth. But it should be limited to people who are symptomatic or aren't walking. So you have an old person who's not walking. They're going to get a blood clot, pneumonia, or bed sore. They have to walk. So for people who don't walk and won't get out of bed, I do kyphoplasties on those people. What do you think, Doug? Do you have any opinions on that? You got to do it within a couple of days, otherwise what's the point? The fracture will heal in 2 or 3 weeks anyway.
Yeah, well, I think when they do outcome studies, if there's any length of time, that people do the same no matter what gets done. If they, if you're talking about a 2-week advantage,
Yeah.
a lot of people would say, it's not worth a 2-week advantage or something.
Right, lay in bed for 2 weeks. I don't want to lay in bed for 2 weeks.
I see a lot of stuff where people are getting multiple level kyphoplasties, and I'm not so sure if there's, it kind of reminds me of the cabbage theory where they go in and they do a bypass and they say, well, this one looks bad too. Let's give them 6 or 8 bypasses. It's
right.
Like, these people have a little bit of osteoporosis. Let's squirt some cement in here and here and here.
Well, that's how it started.
Top them off a little bit.
Yeah, that's how it started. I knew one guy that was the vertebroplasty, he was a vertebroplasty pioneer, and he would do like 10 levels.
Yeah.
Wow.
He would do all of them prophylactically. And a couple people died from that. So the more levels you do, the higher the probability of getting the same cement problem you get with hips, where the lungs shut down.
Norians.
Mm-hmm. You get a functional pulmonary embolism. Mm-hmm. So it's best not to do as few levels as possible.
But the technology is really fascinating, and the ability to do that is pretty unique.
And
also.
some people do fantastic. I mean, some people, you do a kyphoplasty, they're up and walking the next day, and they're really happy, and the pain's gone if you fill the vertebral body well, I think.
So there are 2 types of procedure. There's a kyphoplasty, there's a balloon kyphoplasty, and then there's, what's the other one? Vertebroplasty. And one is where you put a balloon in and supposedly inflate it and push everything out of the way, and then you put the cement in. The other one is where you just go in with a choke car and just squirt some cement in.
Kyphoplasty
Right.
is a master brand. It's actually vertebral body augmentation, but it's like Kleenex. Kyphon's got the market, so everyone calls it Kyphon.
Right. So the question is there any difference of that? And they sort of say that there's less of this or less of that.
When it first came out, they said that it reduces the fracture, but they proved that it doesn't. I was at the academy actually, and there's a really well done thing, X-ray, and it goes, there's no change after doing these. And then the surgeon who was the paid consultant for Kyphon stood up and said this study is worthless because it's not long views. I was like, it's obvious. This is crazy. What's the difference between a spot view and a long view? You still can measure the kyphosis above or below. So I found that was an instance where it was obvious he was out there to damage any kind of poor data for the implant. So nobody even talks about that. And the thing is, orthopedics, when something's not true, a lot of people don't attack it directly. It just fades away. A lot of stuff has done that. Just fade away, and then people realize it's not true.
And no one's been able to prove that you can restore.
It doesn't restore. It doesn't restore. It's been the opposite has been proven. It does not restore the malalignment. But what it does do, Aaron may say, well, why do you do it? It makes a cavity though. So it significantly increases the probability that the cement will go into the cavity and not into the spinal canal. So it creates like a vacuum of space, which I think is beneficial. So otherwise, you have no idea where it goes. It just floats, God knows where. And it could easily go into the spinal canal. So if there's like a big hole, obviously the cement's going to go the path of least resistance into the hole. And you create the hole where you want it with the balloon. Does that make sense?
Now, what are the various techniques for replacing the disc now?
They have all sorts of artificial discs that are in the market now that are made by corporations usually. They're all public corporations, and it's a piece of metal and plastic. They say to avoid adjacent segment deterioration and also increase motion, but those things haven't been proven. The implant costs 3 times as much as the plate and screws in the fusion.
Huh.
So it's a big controversy. A lot of spine surgeons do it now, but it's not clear if it's better than just the standard treatment, which is a fusion.
An industry is seeking approval to do it on 2 levels now, which is very new. It used to be a single level only indication, and now industry's trying to push it to be a 2-level indication.
How is the disc fixated to the vertebral body?
Each different implant's slightly